ICU. They're going to take the next patient who's bleeding. They're going to stabilize them in the operating room. They're going to take the next patient, just like that. The other principle is that really the emphasis is on doing basic interventions, the easiest interventions, and these are probably the most valuable interventions in a disastrous situation. So when there are a lot of victims, the most critical intervention in some type of traumatic incident is probably hemorrhage control. And hemorrhage control is really easy. You just apply point pressure. You hold pressure for 15 minutes, and that's easy. And you can teach that to anyone, but it's easy. Same with basic airway maneuvers. It's easy. Head tilt, jaw thrust, very easy. Those are basic maneuvers that can be done. It's not on complex surgical techniques. It's not on your knowledge of physiology and anatomy that matters. Another principle is that you as a physician may be asked to perform in a capacity that you do not normally practice. So even though Good Sam may not normally care for pediatric patients, if there is a disaster involving many pediatric victims, you may receive pediatric patients. Again, what I said before is that the majority of patients self-transport. They see a hospital, they have a child that's injured, they're going to go to the nearest hospital. So every hospital will receive all types of victims, be it burn, be it pediatrics, etc. And even though LA County, we're lucky in that we do have a lot of pediatric specialty care centers and trauma centers, those centers are going to be overwhelmed too. So you will need to stabilize patients prior to those patients being transferred to a specialty care center. And this is why we say all disasters are local, because you will have to care for whatever patients come to you, and patients will come to you. This is also why we say that at a minimum, we want every single hospital to have the capacity to care for every type of victim. And so we want even hospitals that don't normally care for kids to have a Broslow tape so they can do age and weight-based dosing for medications, et cetera. They should have pediatric endotracheal tubes and laryngoscope blades at some basic level. There should also be a mechanism whereby you have some type of just-in-time training so that if you're not usually accustomed to caring for burn patients, at least you have some algorithm or some basic slides that you can use to educate your staff to care for these victims. I do want to emphasize that in LA County we are lucky because we do have this hospital preparedness program. And so, for example, the burn surge program, the trauma burn surge program, the trauma disaster resource centers, of which there are 14, they stockpile equipment and whatnot so that if a non-trauma center receives victims of trauma, they could make use of the equipment and supplies that are stored at our DRCs. Similarly, the pediatric surge program exists and it's in development. For example, they did a gap analysis recently to determine what our capacity was to care for pediatric victims. And they are developing educational programs, just-in-time training booklets, so that these can be distributed to all hospitals in LA County so that all hospitals are prepared to a certain extent to care for both pediatrics and burns and trauma. This is an anecdote from the New England Journal of Medicine that struck me when I was reading it. This is a summary of events after Hurricane Katrina. So there was a woman by the name of Joyce who said, "What can I do to help?" And she was the newest member of the Baton Rouge field headquarters of the American Red Cross. And in the description of Joyce in the New England Journal, they said, "Through those early days of frantically assessing the safety and needs of the population and planning the medium-term response, Joyce was one of the most valuable members of the team. Without question, without complaint, she made copies, gave directions, ferried people around in her car. Her only expectation was to help. She had dropped everything to volunteer. She had left her work, her daughter, her grandchildren behind, and at the end of her 2-week session, she would return to her life. Another of the many anonymous volunteers who responded to the crisis. Once back at home, she would resume her usual work as a thoracic surgeon." And so, there will be, menial tasks that need to be done, but wherever you can help, the best thing is to be flexible and be willing to do different tasks that you may be asked to do. I thought that was very humbling. Okay, so the expectant category is a category that is difficult for all of us as providers to consider. No one really wants to say this person is not salvageable. This is just not something that we normally do on a daily basis. But in a disaster situation, when you're trying to do the most good for the most people, this may become necessary. It also allows the providers to focus resources on potentially salvageable patients. It's a category that is needed really if there are just not enough resources available to meet the demand. And whether or not there are expectant patients really should depend upon the magnitude of the incident, the available resources, which hopefully will change. You know, in the immediate aftermath, you may not have resources, but hopefully as resources filter in from elsewhere, you may be caring for victims that previously you would have labeled expectant, but now you think that you have the resources to care for them, and they would be labeled immediate patients rather than expectant patients. It also depends upon a provider's level of comfort with using the category of expectant. And many people are not comfortable saying that this patient is expectant. Okay, so an example of a patient who you might debate, is this an expectant patient or an immediate patient? So let's take a 32-year-old male who has a blood pressure of 80/60. His GCS is 15. He has multiple injuries, including shrapnel to the left upper quadrant. He has free fluid on an ultrasound in the emergency department. He has a bleeding scalp wound. He's hypoxic to 85%, and he's still hypotensive after a chest tube is placed, and he's received multiple liters of IV fluid. So if there are 5 critical patients, you know, maybe you do have enough resources to care for him. You would probably label that patient an immediate. But if there are 50 critical patients, you're probably going to have to label this patient an expectant patient and write him off. And obviously, if there are 500 critical patients, that patient's an expectant patient. So there are some thoughts, you know, depending upon what resources you have, given that the case fatality rate for a person with an injury severity score greater than 15 is, you know, greater than 5%. If there are 500 patients with critical injuries with an ISS greater than 15, you might consider a patient with an ISS greater than 15, all of them expectant. You might also consider making those with a GCS less than 5, so those patients who would need to be intubated, all expectants as well, given their high case fatality rate. You may not even have ventilators anyway to keep them on a ventilator. Because of the expectant category, obviously this brings into play the whole issue of ethics. And this is a basic ethical framework for disaster triage. So fairness. By fairness, we mean that the triage process is inherently just to all individuals, and that the process itself treats all individuals equally who have equal needs. By duty to care, we mean that physicians have a duty to care as best as they can for all victims of the incident. The duty to steward resources, by that we mean that physicians have a duty to attempt to obtain the best outcome, again, for the greatest number of patients with the resources that are currently available. By transparency, we mean that the process of triage and the criteria for triage should be as transparent as possible. By consistency, we mean that the process should be applied in the same way to all presenting for care. By proportionality, we mean that the degree of resource restriction would be the same to all, would be proportional to the demands, rather. And by accountability, we mean that we should be able to defend the decisions that we make and be answerable to them. And this might involve documentation and potential review of decisions by institutions and agencies. So some of the factors that could influence your resource allocation, one example of this is the American Medical Association organ donation criteria. So you might want to consider things like, what is the likelihood of benefit to this person? How could it change their quality of life? How long would it benefit this patient? The urgency of the need and the amount of resources required. The AMA says that in terms of organ donation, you should not consider these things. You should not consider sex, race, the ability to pay, social worth, the perceived obstacle to treatment, the patient contribution to illness, like whether or not it's self-inflicted, like alcoholism or smoking, and past resource use of the patient. I thought I could bring up an example of, say you have a scarcity of oxygen, how might you deal with it? So you would try to reallocate limited oxygen supply to patients who need it most, obviously. You might restrict the oxygen flow rate because then you would use less oxygen. You might want to restrict the use of nebulized treatments because, again, that would use more oxygen. You might say no one should get an albuterol nebulized treatment. Instead, they should get only the MDIs. You might want to revise your clinical targets. Usually we're only comfortable saying keep the oxygen saturation greater than 92%. You might say, well, in this case, you might want to decrease that target to 88% or 87%. And you may consider reusing oxygen equipment and delivery devices after appropriate disinfection or sterilization. Yuck. But you might have to do that. But the big question, I think, that arises when people talk about allocating resources is this question. So if I allocate resources in practice crisis, quote unquote, or quote, altered standards of care, will I be sued for malpractice? And the one case that has gotten a lot of press is the case of Dr. Anna Pugh after Hurricane Katrina, who was a cancer surgeon, and she worked at the Louisiana State University School of Medicine. And basically, she implemented some intentional euthanasia. And after that incident, prosecutors made a case to convict this physician. The good news was that ultimately the Orleans Parish Grand Jury refused to indict her, but it is often cited as a reason for malpractice or liability reform in the aftermath of a disaster. The Institute of Medicine, in response to this question, created a schema of medical care rendered during disaster in a continuum. So they said that basically it could be conventional care, which is basically when you use your usual resources and stretch them a bit. You use your usual number of beds, staff, etc. Followed by contingency care, which is when you start adapting what you have, such as using the post-anesthesia care unit to care for some of these victims, to crisis care or altered standards when you basically are doing what you can with what is available. And this is the schema that you have. So just say your facility is severely damaged, you can't even use your hospital, you may resort to using classrooms and the conference rooms to care for patients, and that would be your patient care area, and that's crisis standards of care. But if you had a hospital available, you could potentially, use the PACU. And then, obviously, if you're in normal situations, then you could use your usual bed space. This is a pretty controversial topic, this whole issue of crisis standards of care. And there have been several articles in the Annals of Emergency Medicine debating it as to what this actually means. Does it mean that we're free to practice medicine like we're in the third world? I don't think so. Basically, I think really when we talk about crisis standard of care, we really mean that we would not reduce the legal standard or duty of care for medical responders. Rather, we would say that we would uphold the standard that dictates what a prudent healthcare provider would supply under similar circumstances. So by that, here's an example. So after the Haitian earthquake, what would a reasonably prudent surgeon do if he were confronted with a patient requiring a life-saving amputation, but he has no surgical equipment available? Would it be standard of care to use a hacksaw sterilized by fire? Would that be consistent with his legal duty to care and the medical standard of care, given the limited resources? And I think a prudent surgeon would say, given that scenario, that probably meets the medical standard of care, even though today at Good Samaritan, obviously that would not meet the standard of care. So a few things about crisis standard of care and liability concerns. Once a disaster is declared a federal disaster, restrictions may be lifted, such as the 4-to-1 nursing ratio, as well as HIPAA, depending upon your state and federal regulations. There are also other governmental waivers of regulatory requirements regarding space, staffing, et cetera, that would be lifted once the incident is labeled a federal disaster. The problem with that and the reality of it is that it often takes 2 to 3 days before a disaster is actually declared a federal state of emergency. So it doesn't actually happen in the immediate aftermath of the incident when you may be faced with this influx of disaster victims. So like in Madrid and London, in those few hours after the incident occurred, the federal government is not going to say, this is a federally declared disaster. The 4-to-1 ratios are lifted, the HIPAA violation, those don't apply. For me, this is just my opinion, but for me, in the immediate aftermath, I would say that because the federal government will not step in immediately, even if they have the best intentions to do so, this raises the importance of documentation. So if you're going to be labeling someone expectant that you normally would not, or you're going to be using a hacksaw to perform an amputation, I think one of the best measures would be to document why you think this patient is expectant, document why you needed to use a hacksaw to perform this amputation. And I think there would be some benefit in 2 physicians documenting why. There may not be that much time, but I think 2-physician documentation would be very valuable. So other realities, as I mentioned before, if there are a lot of victims, surgeons may only be performing damage control surgery where they're just tamponading bleeding. Other considerations would be saying, maybe patients that warrant a surgery longer than 2 hours shouldn't be taken to the operating room at all. If the ICUs are full, maybe damage control surgery shouldn't even be performed, and maybe those patients should be labeled expectant. And perhaps patients with injury severity scores that are greater than 15 or a GCS less than 5 shouldn't be operated on either. And some Red Cross surgeons actually say that, espouse the concept that everyone should wait overnight. No one should be operated on in the very first day, because that way you won't expend your resources on high utilizers. And the patients who will most likely be viable will declare themselves. So the reality is really that 3 kids in a bed might be a reality. You may not have 1 person in 1 bed. There may be 2 to a bed. You may have 8 people in 1 room rather than 2. So in conclusion, the mass casualty triage, basically we emphasize the population good rather than the individual good. We emphasize stabilizing the individual, doing basic maneuvers, such as point pressure to a bleeding wound, basic airway maneuvers, head tilt, jaw thrust, versus actually healing a patient. And the ability of all physicians to care for all types of patients, even patients that you don't normally care for, like pediatric patients or burn victims. And for providers to be very flexible in what they're willing to do in the aftermath of a disaster. If it means that the greatest good for you at this very moment is to make a copy of this patient's medical record, even though you're a cardiothoracic surgeon, maybe that's what's needed. And yeah, you may have to step in to make some copies. Also that in a disaster situation, you will be making decisions with very little information, and we may need to implement what we call altered standards of care or crisis standards of care. I just have a list of references at the end. If there are any questions, please feel free to ask. Yes?
What's the difference between what this unapproved is and declaring a patient expectant?
I think there's very little difference in that, quite honestly, except that expectant is a term that's used really for triage, but triage is a dynamic process in my opinion. So triage occurs in the field, but those field triage systems were made for the pre-hospital setting. But triage occurs in the emergency department. Triage continues to occur because you're reassessing their vital signs, you're reassessing what type of resources that you have available. And Dr. Pugh, you're right, she triaged. She said, this patient, given the resources that we have right now and the time it's going to take for the helicopter to come and rescue this patient, no way. Make this person comfortable. Practice intentional euthanasia. So that's what she did. Yeah.
I would imagine that in a real crisis situation, an overflow situation, the documentation would be kind of a disaster.
Yeah.
And I'm just wondering, and it may be in your references, are there systems available to refer to for us to prepare for that? Because that's probably important.
I don't know of any. You know, you're right. In most disaster situations, you are going to be rushed. And as I mentioned in, I think 9/11, many patients were cared for and had no documentation. But I think in a situation in which you're faced with a critical situation, like labeling someone expectant or removing someone from a ventilator, I think that's the time when you would try to document. Whereas maybe if you're taking care of a bleeding wound or a laceration repair, perhaps those are the cases in which you would say, I don't have the time to document that I used 4O nylon and I performed